Good morning, everyone. I'm Gina. I'm a first-year Med-Peds Nephrology Fellow, and this morning I'm going to talk about the care of the adult patient with cystinosis. Cystinosis has historically been something that's been considered a pediatric form of kidney disease, but as I'll go through in the talk, our cystinosis patients are now living well into their 40s, so these are patients we'll be caring for on the adult side as well. So I will start with a case, then go through some basics of cystinosis, including the history of the treatment of cystinosis before going through some updates for cystinosis treatment that have come about just in the past couple years. Then I'll talk about my personal favorite transitions of care for cystinosis patients, and I'll finish up with a patient perspective. So this was a case that I saw in residency. An 11-month-old boy presented with a 1-month history of vomiting associated with weight loss and constipation. He had recently been admitted with a non-anion gap metabolic acidosis as well as hypokalemia that corrected with isotonic fluids and potassium supplementation. During that recent admit, he had a KUB that demonstrated abundant stool burden. And so it was felt that his constipation was functional constipation, and he underwent a Miralax clean out and then was discharged home. This patient then returned with further vomiting and weight loss. Anytime he was offered his bottle, he pushed it away and cried. If he did feed, after feeding, he would gag and vomit. And at the time of presentation, he had not had a bowel movement for 2 days prior. At this point, the patient carries a diagnosis of failure to thrive, meaning that he had crossed 2 major curves on the growth chart and he was less than the 3rd percentile weight for height. Aside from all of this that has been going on, he has no other past medical history. So our patient comes in with a temperature of 98.3, blood pressure that's elevated at 122/82, heart rate of 143, respiratory rate of 48, and he's stable on room air. On exam, his anterior fontanelle is open, soft, and flat. He has moist mucous membranes, a cap refill less than 2 seconds, and normal skin turgor. So this patient, vital signs look good, aside from the fact that he is quite hypertensive. And on exam, he's euvolemic. And then our laboratory findings. So we had a BMP that demonstrated a sodium of 134, potassium of 2.5, chloride of 108, bicarb of 12, BUN of 6, and creatinine of 0.6, which is elevated for age. His glucose was 90, calc, mag, and phos were 11.2, 2.1, and 2, and uric acid was 1.3. So anything that is abnormal for an adult patient I haven't highlighted, but that would be abnormal for our pediatric patient as well. His TSH is 0.66, renin and aldo are both elevated at 62.5 and 222. His urinalysis shows 2+ glucosuria and trace proteinuria. And so at this point, we have a patient who's hypokalemic, hypophosphatemic. He has a low uric acid and elevated creatinine, and urinalysis shows glucosuria and trace proteinuria. And then additional studies demonstrate phosphaturia, an elevated urine protein to creatinine ratio, and severe generalized aminoaciduria. So looking at this patient with a non-anion gap metabolic acidosis, a urine anion gap, glucosuria, phosphaturia, aminoaciduria, initially we are concerned for Fanconi syndrome. So in further workup of this patient, of course, he presented with constipation, which initially was presumed to be functional constipation. And so he got another KUB to look for elevated stool burden. And on this KUB, we saw delayed ossification of the femoral heads and widening of the metaphyseal ends, which you see circled there on the film. So essentially, we see radiographic findings of rickets. Ophthalmology was consulted and they found that the patient had a normal slit lamp exam, and I'll go through why that was later. So this patient ultimately was diagnosed with cystinosis. And while cystinosis itself is an uncommon diagnosis, it is the most common cause of Fanconi syndrome in infants in Western countries. So like I said, in this patient who came in with a BMP and urinalysis really concerning for Fanconi syndrome, the top thing on our differential diagnosis was that this patient had infantile nephropathic cystinosis, even though that is a very uncommon diagnosis. The incidence is estimated to be about 1 in 100,000 to 200,000 live births. And there are about 400 cases that are reported in North America. This is the most current number that I could find. And of those cases, about 200 to 300 are in the United States alone. The first patient with nephropathic cystinosis who underwent transplant, and this was at the age of 10 in 1968, lived well into his 40s. So while it might seem strange that I'm talking about infantile nephropathic cystinosis, these are patients we're now going to be seeing on the adult side as well. So this is a cystinosis registry. This is the NAPRTICS registry. NAPRTICS is a North American Pediatric Renal Trials and Collaborative Studies Consortium. And through this registry, they hope to aggregate all of the data from the cystinosis patients across the US. So we have better epidemiologic data, better data in terms of how patients are doing with regards to treatment. And then with the green arrow, you see that I've highlighted one important factoid, and that's that this registry is for pediatric and young adult patients up to age 25 with cystinosis. But patients that are living past 25, which as I've talked about, now patients are commonly living past 25, we don't have a lot of data to talk about how they're doing, what sorts of treatments they're receiving. And that's certainly something that I want to highlight during this talk. So first, I'll start with what is cystinosis. So cystinosis is an autosomal recessive mutation in the CTNS gene on chromosome 17p13. Individuals heterozygous for cystinosis are entirely normal. There are more than 100 pathogenic mutations in the CTNS gene, the most common of which is a 57 kilobyte deletion. This is prevalent in 50% of Northern Europeans with cystinosis. This genetic deletion can be traced back to Germany and then came to the United States by way of Iceland. This is the most common genetic defect in cystinosis patients in the US, and this will become important as I talk through treatment updates for cystinosis patients. With this genetic defect, you have removal of the first 10 exons and lack of expression of the protein cystinosin. So on the right, I have a graphic that demonstrates what cystinosin is. So it's a lysosomal cysteine and hydrogen symporter. And so without cystinosin, cysteine itself accumulates in lysosomes, cannot leave those lysosomes, and it does so in every organ system of the body. With accumulation of cysteine in lysosomes, you also get crystallization. And with accumulation of cysteine crystals, you get mitochondrial dysfunction, oxidative stress, inflammation, and apoptosis. Over time, this crystal accumulation leads to systemic dysfunction, again, in nearly every organ system. But there's different susceptibility of different cell types to cysteine. Renal cells, particularly proximal convoluted tubule cells, are particularly susceptible, which is why many of our patients with infantile nephropathic cystinosis first present with renal findings, and also why infantile nephropathic cystinosis is really considered to be predominantly a kidney disease, despite the fact that it's really a systemic syndrome. So there are three main types of cystinosis. The first is infantile nephropathic cystinosis. This is the most common type and the type that I'll focus on the most, as these are our patients that are now living well into adulthood. This presents between 6 to 18 months of age. Patients progress to ESRD by 10 years of age if not treated by cysteamine, which is the mainstay of treatment for cystinosis. Patients frequently present with Fanconi syndrome, and they're also hyperaldo at presentation, which is why our patient had both a bumped renin and aldo level. Another form of cystinosis is juvenile cystinosis or intermediate cystinosis. This presents more so with glomerular impairment as opposed to Fanconi syndrome and has a slower progression to ESRD. And the last form of cystinosis is ocular cystinosis, which is also known as adult or benign cystinosis. And this presents with cystine deposits just in the cornea and the bone marrow with no renal involvement. But even in patients with ocular cystinosis, it is recommended that they have consistent screening for nephrologic findings, both for Fanconi syndrome and UAs for glomerular involvement. And again, that's because in patients greater than 25, we just really don't have great data in terms of how they're doing with cystinosis. So again, I'm going to focus on infantile nephropathic cystinosis. So children with nephropathic cystinosis frequently present with Fanconi syndrome, as our patient did. They present between 6 to 18 months of age with clinical findings of polyuria, dehydration, and weight loss, things that our patient had. Our patient also came in with concerns for constipation, and I would really argue that that was because the patient wasn't feeding well, was quite dehydrated, and that's why they were constipated. On chart review, you'll see recurrent hospitalizations for gastrointestinal illnesses, and that's really why I like to highlight this clinical case of the 11-month-old that was diagnosed with nephropathic cystinosis. While it is the most common cause of Fanconi syndrome in the US, it's still a really difficult diagnosis to get to. And so a lot of times, by the time we see these patients as adults, they've really had a tumultuous story, even just getting to that diagnosis. Lab findings for Fanconi syndrome, of course, are a non-anion gap, metabolic acidosis, urine anion gap, hypokalemia, calcemia, and phosphatemia, a low serum uric acid, just like our patient had. They'll have phosphaturia, glucosuria, tubular proteinuria, which is why we get the protein to creatinine and not albumin to creatinine ratio in these patients, amino aciduria, and then they'll also have cystinuria. And I really want to highlight the cystinuria because a lot of times patients with cystinosis are confused with patients with cystinuria. And while patients with cystinosis do have cystinuria, they don't have the subsequent cystine stone formation. And that's because they have dilute alkaline urine. So cystinuria, but not cystine stones, more so cystine crystals that are deposited in every organ system.
Gina, it's Isaac. May I interrupt you for just a moment?
Yes.
I'm curious, you listed here hypocalcemia. The index case you presented had hypercalcemia. If I saw it correctly, I think it was 11.
Yeah, that's a good point. To be honest, I hadn't thought through that in this patient.
And the mechanism of the usual hypocalcemia, is it hypomag or?
My understanding is that it's urinary losses.
Mm-hmm. Okay. All right, thanks.
Thank you.
And I think you mentioned that the patient had rickets, correct? So I imagine was vitamin D deficient?
Yes, and hypophosphatemic rickets was the kind of etiology for that.
So that could be the mechanism also in the hypocalcemia. I wonder if was an FGF23 measure, Gina, do you know?
Not in this patient, it wasn't.
Not in this patient, okay.
No. Oh, that's helpful though, thank you. Okay. So these patients do also present, just like we were talking about, with hypophosphatemic rickets, and clinically in infants, this is seen as delayed walking. And then lastly, they have corneal crystal deposits. These three kind of big buckets are the first findings of patients with infantile nephropathic cystinosis. And these corneal crystal deposits are seen on slit lamp exam, which is why our patient had a slit lamp exam to evaluate their eye findings. This presents in the first few years of life. So our patient that presented at 11 months of age had not yet developed these corneal crystal deposits. And this clinically can be seen with photophobia. This graphic is really just to highlight that children with cystinosis have systemic findings in almost every organ system of the body. In the green boxes, I've highlighted what we see on the pediatric side in terms of patients with infantile cystinosis, but then all of the other boxes are things that we'll see when we care for adult patients with cystinosis. And so some I'd like to highlight are hypothyroidism. Patients are often on levothyroxine, insulin-dependent diabetes, primary hypogonadism in male patients with cystinosis. Other findings are musculoskeletal findings like difficulty swallowing and feeding. Neurologic findings include the cystine encephalopathy, as well as impairment in visual motor function. And then they have pulmonary insufficiency as well. And this graphic is really just to highlight that as patients age, they have a lot more systemic findings of cystinosis. And so we will be the ones that really see patients with all of the systemic sequelae. So diagnosis of cystinosis. So you can diagnose cystinosis on a slit lamp exam alone, which is why our patient again had that exam. And you'll see corneal crystals as pictured on the left. This is most common in infants older than 1. We also can test for white blood cell cysteine levels. This is also what we trend when we treat patients for cystinosis. Those will be elevated. They'll be 50 to 100-fold that of normal. And plasma cysteine levels are normal. Genetic testing is possible for cystinosis patients, predominantly for that 57 kilobyte gene deletion, which is the most common genetic deletion that we'll see in the US. And then you also can diagnose cystinosis prenatally via amniocytes or chorionic villi. And the reason why this is important is, as I said earlier, patients who are heterozygous for the CTNS deletion are entirely normal. So if parents give birth to one child with cystinosis, they might want prenatal testing for a second pregnancy. It's also important because there are case studies of female patients with cystinosis giving birth to healthy children. There have yet to be any male patients with cystinosis that have fathered a child in the US because they have primary hypogonadism, but actually in Germany, there have been case studies where male patients have undergone fertility treatments and been able to father children and healthy children. So pathologically, cystinosis can be seen on light microscopy and electron microscopy. Of course, because it's a proximal convoluted tubule lesion, you'll see the swan neck deformity. And then with progression to a glomerular lesion, you'll see focal segmental sclerosis. On EM, we see cystine crystals in tubular cells, and podocytes are hypertrophic, multinucleate, and have foot process effacement.
What is swan neck deformity?
I didn't include a picture. It essentially is, gosh, it's hard to describe, but it looks exactly like that description sounds. It's just kind of a curving of the proximal tubule cells.
I'll Google it. All right, thanks.
Yeah. All right, and this is our historical treatment for cystinosis patients. So cysteamine is really the mainstay of treatment for any patient with cystinosis. So we start at 10 mg per kg per day and titrate up to 60 to 90 mg per kg per day. And this really has to be divided every 6 hours. So despite the sleep-wake cycle, to the best of our ability, has to be given around the clock, Q6. Goal levels are less than 1 nanomole, half cysteine per milligram protein. So we're really trending that white blood cell cysteine level. And the role of cysteamine is that it converts intracellular cysteine to cysteine with an EI and cysteine-cysteamine mixed disulfide. So you can see that here in the graphic, and I've circled in red the cysteine and cysteamine-cysteine. And these are able to leave the lysosomal cells without needing that cystinosin symporter. And with this treatment, 90% of cysteine can be depleted. Another treatment for cystinosis is the cystamine hydrochloride eye drops. So as I said earlier, patients with infantile nephropathic cystinosis also frequently present with corneal cystine crystals, and these eye drops can clear the cornea entirely within 1 to 2 years. And they're administered 6 to 12 times per day. When you think of kind of that dosing schedule, that really just means every waking hour patients have to use these cystamine eye drops. And lastly, treatment includes replacement of renal tubular losses. So cysteamine actually has very little effect on Fanconi syndrome, and I'll go through kind of the mechanism for that a little bit later. So we really just have to treat the Fanconi syndrome with replacement of what is lost. So sodium potassium citrate, sodium phosphate are also administered to these patients. So cysteamine treatment. So cysteamine treatment began with Cystagon. This was discovered in 1976, was commercially available in 1997. And a Cystagon is what we have to give every 6 hours around the clock, regardless of the sleep-wake cycle. Then in 2013, Procysbi was developed, and this was considered a relatively new treatment for cystinosis, and that enabled BID dosing as it's a delayed release form. So now all of our patients are on Procysbi. Side effects of any form of cysteamine treatment are halitosis, body odor, nausea, and abdominal pain. Also copper deficiency, which is felt to be because of the cysteamine administration, there's copper losses in the urine. It's not very well described, but that's the presumed mechanism right now. And that comes with bruise-like skin lesions, bony abnormalities, and muscle lesions. And then limitations of cysteamine treatment are that it's effective for kidney disease. It can slow the progression of kidney disease to ESRD, slow the need for transplant, but it cannot preclude the need for renal transplant. It's also effective for the thyroid. So in patients with cystinosis who have hypothyroidism, who once needed levothyroxine, a good cysteamine regimen can actually preclude the need for levothyroxine. And then it's effective for some CNS sequelae. So it's effective for the cystinosis encephalopathy, but visual motor disturbances are still going to be present in patients with cystinosis on cysteamine treatment. So again, treats some of the organ system findings of cystinosis, but certainly doesn't treat all of them. It also doesn't treat Fanconi syndrome. And that is because we think that patients with cystinosis who have Fanconi syndrome have enhanced apoptosis, mitochondrial dysfunction, oxidative stress, aberrant autophagy, endolysosomal dysfunction, and decreased expression of megalin and cubilin. So additional mechanisms for Fanconi syndrome aside from just the accumulation of the cystine crystals themselves. And then lastly, cysteamine treatment is not considered safe in pregnancy. As I said earlier, there are cases of female patients with cystinosis giving birth to healthy children. And in those patients, it is recommended that they are not on cysteamine while they're planning a pregnancy and are pregnant. Transplant is also, of course, an option for cystinosis patients, and cystinosis does not recur in the kidney graft after transplant has been performed. Extrarenal manifestations do ensue though, and so cysteamine therapy should be continued after transplant. And again, as patients with cystinosis really first present with renal findings, even in patients who have been transplanted, the nephrologist is really looked to kind of titrate the cysteamine therapy in these patients, even though it's no longer being used to treat kidney disease. All right, and now I'll go through some recent treatment updates for cystinosis patients. So the first update I'll talk about is geneticin. And so the background for this is that 15% of patients with cystinosis have a nonsense mutation that halts the translation of the CTNS protein. The hypothesis of this study is that geneticin can actually bind the ribosome, relax translational fidelity, and permit read-through of the nonsense mutation, resulting in functional cystinosin protein that cysteine is able to leave the lysosomes through. So this study was published in 2018, and they found that after treatment with geneticin for 48 hours, CTNS transcript levels were increased to within the normal range. The protein was expressed, and half cysteine level reduction was achieved that was comparable to that achieved by cysteamine after 1 hour. So really promising results. Strengths are that this would be a better systemic treatment for cystinosis. So this can target cystine crystal accumulation and potentially have effects not just in the kidney, the thyroid, and some CNS sequelae, but better systemic treatment. Weaknesses are that this, of course, would only be beneficial for patients that have a nonsense mutation in cystinosin, or a nonsense mutation in the CTNS gene. And that nonsense mutation is the W138 mutation. That's the one that's most commonly seen. This is prevalent in 50% of French Canadians who have cystinosis, and that was spread by way of Ireland. So it's not effective in the 57 kilobyte deletion that we see in 50% of Northern Europeans, the one that I've already highlighted, that's most common in the United States. And then the greatest weakness is that geneticin toxicity precludes its use in humans. So there was another study done by Hillip and Woolley in 2001 that found that gentamicin can also induce read-through of nonsense mutations, and this can be applied to cystinosis patients. But you don't actually see results from geneticin treatment or beneficial outcomes of the geneticin or gentamicin treatment, until after 15 days. So no reduction was observed at 48 hours. You had to have 15 days of treatment to see a reduction in the intracellular cysteine levels. Problem with that, of course, being that you're on an aminoglycoside for 15 days. So renal toxicity, ototoxicity, and then for patients with cystinosis, of course, presumably this would be a lifelong therapy. So then you really have to think about, what does lifelong treatment with an aminoglycoside look like? So I think this is exciting, thinking about the fact that we could have a treatment for patients who have genetic diseases from any nonsense mutation, cystinosis and other diseases, but not quite there yet, just because of the great side effects of aminoglycosides. Another treatment update is luteolin. So this study was actually just published in 2020. The background is that not all clinical sequelae are secondary to lysosomal cysteine accumulation. Lysosome-mediated autophagy is also compromised. This is something that I talked about in patients with Fanconi syndrome, that there are other mechanisms that the kidney sees to create the Fanconi syndrome, not just intracellular cysteine accumulation. And so in these cases, lysosomal dysfunction contributes to defective clearance of damaged mitochondria, and you get accumulation of the substrate P62. And this is seen in kidney biopsy specimens as well. And so this study proposed that we can use ELISA to identify drugs that actually reduce the level of this P62 substrate in proximal tubular cells. And the drugs that do this potentially could be great therapies for cystinosis patients. And so the study used ELISA, demonstrated that luteolin was a potential drug that can decrease P62 levels. And the results were that luteolin improved autophagy lysosome degradation pathway. It protected against apoptosis, decreased oxidative stress, restored megalin expression, and enhanced protein reabsorption in the proximal convoluted tubule. And most importantly, it had a good safety profile. So this was a really promising study, again, just published in 2020. And so strengths of this study would be that it would be luteolin is a treatment for Fanconi syndrome. So instead of treating with cysteamine and then having renal replacement for what's lost in Fanconi syndrome, we could treat the Fanconi syndrome itself. Again, luteolin is safe. It's a natural flavonoid present in various fruits and vegetables. And then weaknesses are that it's not going to have any effect on cysteine storage. So again, it's a totally different mechanism of cystinosis that it's working on. So presumably this would be an adjunctive treatment for patients with cystinosis, so luteolin plus cysteamine. And then another weakness is that this study was only done in animals with the 57 kilobyte deletion. Again, that is the most common deletion in the United States, most common deletion in Germany, but in patients who have other mutations, would luteolin still be a viable option? Another treatment update is the use of a cysteamine microsphere thermoresponsive gel eye drop. This study was just published in 2021, this year. And so the background is that corneal cystine crystals are treated currently with cysteamine eye drops, as we've discussed. These eye drops are administered 6 to 12 times per day, every waking hour. And the bottle of drops themselves is actually only stable for 1 week. So these patients have weekly trips to the pharmacy to get their eye drops. And so the hypothesis for this study is that cysteamine-loaded microspheres within a thermoresponsive drug carrier will demonstrate improved stability and reduce dosing frequency as compared to cysteamine eye drops. And that's just what the study showed. The eye drops were more stable. Cysteamine was stable at 7 weeks at 4 degrees Celsius and 5 weeks at 25 degrees Celsius. So no more weekly trips to the pharmacy. It had sustained release, and subjects were shown to have the drug still present in their eyes for 24 hours. So again, a gel every 24 hours as compared to an eye drop every waking hour is quite an improvement. So strengths: improved dosing, improved stability. Weaknesses are with cysteamine eye gel, you can get stinging, burning, and redness for 1 hour after administration of the topical eye gel. This is actually also something that we see just with the cysteamine eye drop, so not a big change for those patients, unfortunately. And then another weakness that I've read about is that with the use of the eye gel itself, you actually can have kind of a cornea or a cloudy layer on your cornea, so you can have some blurred vision immediately after putting on the eye gel. And then in talking about treatment updates, I think it's very important just to mention stem cell transplant as well. So hematopoietic CTNS carrying stem cells from wild-type donors have been successfully transplanted into cystinosis mice. And with those mice, we've seen long-term improvement of renal function, including the Fanconi syndrome that's not treated with cysteamine. We've seen reduction of cysteine content in different tissues up to 94%. And then we've also seen that it's effective in older mice. So potentially a treatment for patients if the tissue injury has already occurred as well. There has been one case report of a 16-year-old male with cystinosis who's had a stem cell transplant, and the stem cell transplant itself was successful, but he did pass away of side effects of the transplant 3 years later. All right. And so since we will be seeing adult patients with cystinosis, I think it's also important to discuss the models that we have for transitions of care for patients from the pediatric side to the adult side. So this on the left, you see a transition guide. This is through the Cystinosis Research Network. And this transition guide is really for teens and young adults with cystinosis and their families. So it's a patient perspective on cystinosis. And while I won't talk through all the clips that I have included in this section of the PowerPoint, I just think it's interesting to kind of reference this guide and see what transitioning looks like from a patient perspective as well. So the term transitioning came into use in the late 1980s. Surgeon General C. Everett Koop noted that children whose lives he had saved through surgery were now surviving into childhood and adolescence. And he described transitioning as the one major issue for chronically ill adolescents that has not yet been addressed by the healthcare system. So I'm going to go through two different models for transitions of cystinosis patients. To my knowledge, these are the only two models that have been created and looked at for cystinosis patients. And so one is the RISE protocol, and another that I'll touch on more briefly is a COC program, the Cystinosis Outpatient Consultation Program. So the RISE protocol, this was done here in the US, and the hypothesis was just that, background information is that patients undergoing transitions have increased risk of serious adverse events, such as graft loss, progression of disease. This is something that's been really well documented, particularly in transplant studies for pediatric patients who have gotten kidney transplant and then transitions to adult care. That transition period is a really high risk period of time. And the hypothesis was simply just, let's create a structured protocol and see if this can be beneficial. So the RISE protocol is a protocol based on 4 key competency areas: recognition, insight, self-reliance, and establishment of healthy habits. So that's where the RISE mnemonic comes from. So for recognition, that talks about recognition of one's disease process, of treatment, of recognition of the healthcare system and personal goals. Patients are evaluated for insight into their short and long-term impact of their disease and treatment of their disease. There's a focus on self-reliance and self-management of medications and appointments, and there's a focus on establishment of healthy lifestyle choices. So the RISE protocol really puts patients into 3 different transitional stages: pre-transition stage, during transition stage, and post-transition stage. And so they have milestone checklists to kind of grow from the pre-transition stage into the transition stage, and then to transition to post-transition stage. And each of those milestone checklists are subdivided into these RISE categories. This protocol also includes a cystinosis day, a day during which all providers are seen either on the pediatric side or all providers are seen on the adult side. So some form of kind of aggregation of care into one day. And then after transitions of care, it includes a combined teleconference 6 months post-transition. And this is with both the pediatric providers and the adult providers for those patients. So this is just a graphic showing the 3 different stages. So early adolescence at 14 to 18, this is the pre-transition stage. Late adolescence, 18 to 21, this is the transition stage where patients would be presumably leaving pediatric care and being cared for by adult providers. And then adulthood is defined as greater than 21. And at that point, all of the patient's care should be provided by an adult provider, according to this protocol. This is just, I think, an interesting graphic of all of the team members that they have in the care of these patients. You can see all of the different subspecialties that are involved in cystinosis patients' care. And then at the center, they have the patient. So this is really a patient-centered model for cystinosis care. So strengths of the RISE protocol, again, it's focused on building patient autonomy, really has a patient at the center of the model. It doesn't require a transitions clinic with multidisciplinary care under one roof. And I think that's a really kind of important and noteworthy piece of this protocol. The AAP, the American Academy of Pediatrics, has highlighted that the best model for transitions of care would be a transitions clinic where you can have both adult and pediatric providers that see the patient in the same day under one roof. That, of course, is a really difficult model to create because of time constraints, financial constraints, constraints, all of the logistics that go into that. And so this protocol is more easily implemented because it doesn't require that transitions clinic. Weaknesses of the protocol are that it's untested. Again, the hypothesis was really just to create a protocol, but they didn't talk about outcomes, disease outcomes, and that is something that the study mentions they'd like to do in the future, talk about disease outcomes, loss of graft, things like that with regards to the protocol. I think that transitions begin too late in this protocol. Their pre-transitions phase started at age 14, so 14 to 18, but the American Academy of Pediatrics has a transitions toolkit, which really says that patients should be started on this transitions process, whether that's just meeting milestones, talking about transitions of care at the age of 12, and those are the best models for transitions of care. I think another weakness of this protocol is that care is transitioned from the pediatric nephrologist to both an adult nephrologist and a PCP. So on the pediatric side, these patients really have their care coordination all done by the pediatric nephrologist. They're ensuring that they see all of their subspecialists, they have all of their care, all of their treatment regimen, and then this protocol recommends that we transition that responsibility to both the adult nephrologist and the PCP working together. And I think anytime you have two providers that are both the medical home and the center for coordination of care, there's the opportunity for things to get lost. So I think one person being kind of that medical home would be really important. Or at least if it were to be two providers, maybe two providers working in parallel in the same clinic and seeing the patients at the same time. Another weakness of this protocol is that there's no milestone checklist for after the transition. So they have a checklist for the pre-transition phase, the transition phase, and there's nothing for after the transition. While I know those patients have fully transitioned to adult care, I still think it's important to start talking about their patient autonomy, how they're doing with their disease process, and we just don't have those protocols, and we don't have those checklists after the transition. And this actually reminds me a lot of the Cystinosis Research Foundation, the NAPRTIC Cystinosis Registry that I talked about at the beginning, where after 25, we just don't have data for cystinosis patients. And that's very kind of similar to this RISE protocol, that after 21, we just don't really have a protocol in place for these patients. There's also the COC program. So this program was in Germany. There are approximately 130 patients in Germany with cystinosis, and care coordination was lacking. The hypothesis was by bringing experts together to run 2-day outpatient clinics for patients, the COC would be able to improve outcomes and reduce costs at the same time. So this program was in southern Germany. At this program, they were able to see 75% of those 130 patients with cystinosis every year. Those patients would come yearly for a 2-day outpatient session where they had appointments with 13 different subspecialists. And I think the financial structure of this program is what is difficult to apply here in the US. So it was financed both by health insurance, and Germany has a universal healthcare system, and also by a Cystinosis Foundation of Germany, which is essentially an organization that received donations from individuals and companies. And so costs such as travel, accommodations, and expenses for the providers that were not centered in that area were paid for by the Cystinosis Foundation of Germany, and travel and accommodations for patients were paid for by that system as well. So strengths are that you had coordinated care for 75% of the patients in Germany with cystinosis, lower cost per patient in this model, but of course you also have funds that are coming both from universal healthcare and from this organization, the Cystinosis Foundation of Germany. And weaknesses are going to be, because of those reasons, we have lack of external validity. All right, and I'd like to finish up by talking about cystinosis from a patient perspective. So I think when we see patients with cystinosis, of course, it is a systemic disease. Almost every organ system in the body is affected by cystinosis. And so for me, when I see a patient like this, it's really easy to get caught up in all of their systemic sequelae, all of their medications, making sure everything is going well. But I think it's also interesting to take a step back and think about things through the perspective of the patient and what's really important to them to address during a visit. So on the left, I have a quote from a patient with cystinosis. And this is a quote talking through her perspective and talking with other patients with cystinosis. So she says, "An important issue is the smell of cysteamine. As I've talked with some of the young adults in our community, I found more than one person who has stopped taking cysteamine when embarking on a serious relationship. You cannot talk about dating without approaching the subject of close contact, kissing, etc. with cysteamine. Quite frankly, if you're with someone who's going to make a stink, no pun intended, about your lifeline, he or she isn't worth it. So I thought that was just a really interesting perspective and something that I've seen to be true as well. And that patients with cystinosis, one of the things on the forefront of their mind is the halitosis and the body odor that comes with cysteamine treatment. And so in these patients, some of the things that we can recommend, which I have on the right side of the screen, are vitamin B2, chlorophyll, and breast sprays and body sprays. And essentially what's happening is that cysteamine is metabolized to dimethyl sulfide. It's a volatile sulfur compound that's excreted via the lung and excreted through perspiration. And so my understanding, while there isn't a lot of good data, but my understanding is that riboflavin, vitamin B2, actually assists with the remethylation of this compound so that it isn't excreted through sweat and through the lungs. So something to think about in patients with cystinosis, especially if you find that they haven't been compliant with cysteamine treatment. And that, of course, is the mainstay of treatment right now for cystinosis patients. All right, and then I'll finish up with a patient update on our little guy from the beginning. So he was started on citric acid, sodium citrate, sodium potassium phosphorus, and calcitriol, and he was discharged. After discharge, his white blood cell cysteine level resulted at 7.7 nanomoles per milligram. Again, we target less than 1 nanomole per milligram as a treatment goal for cystinosis patients. And he was found to have a homozygous deletion of the CTNS gene. He was subsequently started on Procysbi. And I just finished up talking about this little guy because, like I've said throughout the talk, now infants that have been diagnosed with infantile nephropathic cystinosis are living well into adulthood. And I think it's just helpful to kind of have the perspective of what they've gone through, even just to get that diagnosis and what they've gone through up until this point when we care for them. Any questions?
Thanks, Gina. I think to Isaac's point, I think you mentioned that your patient's now, well, I know you saw your patient in residency, but he was put on calcitriol. I wonder if it was mainly hypocalcemia more than hypercalcemia what he was presenting with. But a quick question I have is, adult onset of cystinosis is many ocular manifestations. Is that the case?
In the cases with the benign cystinosis?
And adult onset, kind of, when he presents kind of late in life is, yeah.
Yes, mainly ocular findings.
One question, this is Godela. The patients with adult onset cystinosis, do they have milder mutations, like just missense mutations?
Yes, they do have milder mutations.
Hey, Gina, it's Amy.
Hi.
Crushed it, girlfriend. I have a question. I don't remember the drug, but it was the one that gets through the nonsense mutation.
Mm-hmm.
That one is interesting, mostly because I don't really understand how it would work if this medication allows basically reads through the nonsense mutation, because you would think that the protein that then is made is completely non-functional, would cause a lot of problems. So I was just wondering if you can explain that a little bit more, if you happen to know why that works.
Yeah. So I can't say specifically why it works, just that in the study, they did show that they had increased expression of the cystinosin protein and that it was effective in that the cysteine was actually able to leave the lysosomal cells through the cystinosin protein. So I don't know why that, why the read through works and why it's able to kind of create that protein and have protein insertion and have it be a functional protein. But somehow that was the outcome that they saw.
Oh, so by allowing the read through the nonsense mutation, like somehow you get a protein that at least can traffic more normally and then can like kind of get processed in a way where it doesn't cause as much problems. Did I understand that right?
That's my understanding.
Oh, interesting. Snazzy. Thank you.
Hey, that was a great presentation. I have a quick question. So I know you were talking about when you have the treatment that patients have like side effects of halitosis, body odor.
Yeah.
Is that noticed more as they get older, or is it kind of as they're young and going into adulthood?
Yeah, I think unfortunately it is just as soon as they're started on treatment, because of the way that the histamine is metabolized and excreted both through sweat glands and through the lungs. You have that body odor and the halitosis in all patients on histamine therapy. So it's not just something that's like hormonally related during puberty or adulthood.
And is that something that makes a lot of people not want to take it in the future?
Yes, that's the number one reason for noncompliance with histamine treatment. Mhm.
Okay.
Yeah.
Thank you, Gina. Was a great presentation, very interesting.
Thank you.
Yeah, and we used the opportunity to say hi to Sandeep, who has joined our Zoom lecture. Sandeep, hopefully you're doing well. It's nice to see your name. Thanks, Gina.
Thank